Restrictive disease is the next discussion. So you're going from obstructive to restrictive disease. Okay? Restrictive disease is a problem where the expansion of the lung is being inhibited, okay, by alterations in the lung parenchyma, diseases in the pleura, diseases in the chest wall, or diseases in the neuromuscular apparatus. Okay? What I consider restrictive disease is the giant boa constrictor around your chest. So if you begin to think of it that way, it becomes easy to understand. Okay? Whatever would actually act like a band around your chest, okay, and constrict you and not allow you to breathe in, okay, is restrictive disease. It still means everything could be functional, okay, but you're very limited in the amount of volume that you can take into your chest. How a boa constrictor works is kind of interesting. And, you know, being that I lived overseas for most of my life, I got to see what anacondas could do to humans, plus what a regular python could do to an animal. Okay? And what he does is very patient. Okay? As he wraps around your chest, he just sort of looks at you and waits for you to breathe out. Okay? And actually the best way to stay alive is by keeping your chest wall expanded and just breathing very shallow. If you do that, you'll stay alive longer. Okay? If you take in a big deep breath in and out, as soon as you take a breath out, he just tightens up a little more. Okay? And he continues doing that till eventually the lung is down to its lowest state, and now you can't breathe in, and then you asphyxiate and die. So it's not a very fast process. So not very pleasant. The same thing happens with restrictive disease patients. Okay? It's a very slow process. It takes a long time for this to develop. Okay? What you see in this kind of situation is you see the constriction taking place. The diaphragm can still work properly, but the actual limitation is your tidal volume. So your FEV1 to your FVC ratio are decreased equivalently. Okay? So when you look at the actual value change, there is no change. If you see a ratio for FEV1 to FVC, the value percentage-wise is normal. Okay? If you look at the actual numbers, though, the FEV1 and the FVC are both decreased. Okay? So the vital capacity and the expired volume in 1 second are all significantly decreased, but the ratio persists as normal. So what you see in this kind of disease process is you get characterized reduced vital capacity, reduced expiratory reserve volume at 1 second, okay? And you limit your inspiratory reserve volume as well. Okay, so you see this graph showing you in the dotted line is normal, and in the orange is a person with restrictive disease. If you look at the actual flow volume loop, one of the things that you can sort of pick out right away is that the slope of descent, okay, looks exactly the same as a normal individual, okay, which is the expiration, which is this, and this are on the same track, because the bronchioles are fine. So this is not a bronchial disease. Okay? These people have small resting volumes, they have decreased FRC, and airway resistance is usually not affected. Disease of the lung parenchyma it leads to disease of the alveolar tissue of the lung. So as you walk out from the alveoli outwards, there's different causes of restrictive disease. The first one we're going to talk about is the actual banding effect around the alveoli themselves. Okay? You have diseases that are called collagen deposition diseases. Okay? These are diseases that you develop excessive amounts of collagen and you begin to deposit it into the interstitial space of the alveoli. Okay? And that extra collagen basically prevents the lungs from expanding properly. And it's like putting an internal rubber band around each alveoli. It begins to compress them and make them smaller. Okay? What you see in this kind of situation is that, remember I told you yesterday, I was telling the other group yesterday, that if you look at the fenestrations in the lung, the capillaries that are coming into the lung are not tight junctioned. Okay, they're fairly loose junctioned. Okay, 50% of protein that's found inside your plasma can extravasate out into the interstitial space of the lung, which means that it's pretty loose. Okay, Most capillaries in the rest of your body are tight junctioned. Okay? The only other one that's really as loose as that, or more so, is liver. Liver is very loose. It's got huge fenestrations. They look like you're inside of a cathedral. Okay? But these areas will allow this collagen deposition to take place. One of the things that also is important is that the tight junction after that is in the alveolar sac. The alveolar wall lining is very tight. It does not want to allow water from the interstitial space to go into the alveolar sac. So be careful when people ask you that on exams. They'll ask you, okay, are the capillaries loose junction? The answer is yes. But are the alveolar walls tight junction? The answer is they are tight junctioned. Okay? Make sure which one's which. Did I lose you? I lost somebody. Okay. Here's the two membranes that we're talking about. This one is the capillary wall, and this is the alveolar sac wall. This one is tight, and this one is open. So this allows fluid to go into the interstitial space, okay, which is there. Okay, the actual alveolar membrane is very tight junction. So it does not allow fluid to go from the capillary directly into the alveoli. That doesn't happen unless you have disease processes like ARDS. ARDS is when the actual alveolar lining actually becomes separated and fenestrated, and then the fluid starts pouring into the alveoli. You drown in your own secretions. Okay? Now, the type 1 epithelial cells are the chief structural cells. They act as mechanical support cells for the alveoli, and they are very tightly junctioned. You also have type 2 alveolar cells, which are epithelial cells that produce a surfactant, and they replace injured type 1 cells, and once they turn into type 1 cells, they can't come back. Okay? So type 2 goes into type 1. Okay? The alveolar macrophages are usually not found very high concentrations in this area most of the time unless there's an infection taking place. And the reason they can get there is because they can get through the loosely junctioned capillaries. Okay? If you had tight junctions here, the white cells would never get across. The alveolar macrophages tend to be scavenger cells that extrude out. Okay? They usually only come out when the bacteria are usually located there and there's damage. So most of the time, alveolar cells are usually not, the macrophages are not usually out in the alveoli most of the time. You also have cells that produce fibrogen, elastin, and collagen, which are called the fibroblast. Okay? And if you get an overproduction of those due to hypersensitivity reactions, then you can get what's called pulmonary interstitial fibrosis, which means the collagen begins to deposit in here, and you get restrictive disease process taking place. This is a very nice picture of an alveoli showing the nice architecture, showing the overlap of type 1 cells. They're very tightly junctioned. This shows you the alveolar macrophage out here. It's rare in its existence. Normally, most of these sacs are empty of macrophages. That usually would indicate something of an injury pattern or some kind of infection taking place. The alveolar sac inside here is essentially dry. Okay, it's free of water. Okay, what they're not telling you, unfortunately, is that you have inside this sac is you also have soap, which we call surfactant. Okay, and surfactant isn't just like your regular Dove soap. Okay, it's a very specialized substance. It actually has proteins in it as well. It's mostly made up of lipids, sphingolipids, but it also has proteins in it. And these specialized proteins make a huge difference in how the surfactant stacks. Okay? We talk about this in the DNAP, so it's a little bit too much right now. Just understand that the surfactant is really important just to add a stability factor and prevent the alveoli from collapsing. Okay? If you lose the surfactant, the alveoli tend to collapse at a very high rate, and as a consequence, you can't re-expand the lung. The structures of the alveolar wall is made up of the interstitium. The interstitial wall fills the capillary between the alveolar and epithelium. Okay, normally that area is a little bit on the drier side. It still gets fluid in and out, but lymphatics get rid of it very quickly. If you start getting excessive pulmonary edema, okay, that's the first place it goes first. It goes to the interstitium. So the interstitium gives you a certain degree of time before it begins to extravasate into the alveoli. There's two kinds of pulmonary edema. There's type 1 and type 2. Type 1 pulmonary edema, which we'll talk about next hour, but I think I'll get to it, is when it just fills up the interstitial space. Type 2 is when it actually pours into the alveolar sacs. That's much more serious. Okay? If you begin to treat type 1, it's very easy. Lasix, okay, positive pressure ventilation. Usually that's easy problem to fix. Once you're going into type 2, it's a little bit more difficult to fix in that situation. It takes longer to take place. What you see in diffuse interstitial pulmonary fibrosis is you see an increased deposition in surrounding structures. So this is a very nice picture showing you how the fibroblasts begin to form high levels of fibrosis around the alveolar sacs. It eventually causes destruction of the alveolar architecture, okay? And it leads to very dense fibrosis, and you develop what's called a honeycomb lung, okay? When you look at it under microscopy, it looks like a bee's wax honeycomb, okay? So it's kind of cool, okay? Except it's not cool for you if you have a disease, okay? Because your lungs are becoming stiff like a honeycomb, okay? The pathogenesis sometimes can be unknown, but eventually does lead to overall destruction of the lung and can be, the only thing you can do at that point is possibly do a lung transplant for these individuals. This is what a person looks like with this kind of disease. This is the gross picture, okay? This is pretty ugly for a lung, okay? The normal lung should be nice and pink, smooth in appearance, and that looks pretty much beat up. Clinical features is thank goodness, is not common, okay? But unfortunately, what you do see is you see it in adults in the late to middle ages. They have severe dyspnea because their workload is so high. They get tachypnea. They develop significant degrees of cyanosis, and because the cyanosis can become prolonged, they'll develop what's called finger clubbing. Okay? Eventually, the pulmonary hypertension becomes a big issue, and this person will develop right ventricular heart failure from the pulmonary hypertension, which we call cor pulmonale. The other common complication is pneumonia, okay? And that's what usually kills these people is a pneumonia infection. Pulmonary function-wise, you see ventilatory capacity and mechanics. The FVC is markedly reduced. The FEV1 is also markedly reduced. But the ratio of FEV1 to FVC is actually normal. Okay? The forced expired fraction of 25 to 75, because it's not obstructive disease, is normal. Okay? So remember that slope of descent I showed you is unchanged? Well, it's normal. Okay? All the lung volumes are reduced. It's like having a boa constrictor around your chest, so you have total lung capacity, FRC, residual volume are all significantly reduced, but the relative proportions of all these are maintained, which is why the FEV1 to FVC ratio is actually normal. Gas exchange-wise is you're literally doing the same thing a boa constrictor is doing around your chest. You're limiting the amount of ventilation taking place, so you'll see a significant drop in PO2 as well as a rise in CO2. pH is usually normal. Most people begin to hyperventilate until at the end of the disease process, where then CO2 begins to progressively change and increase, and then you get the pH change, but that's late. Exercise causes significant hypoxia, and as for control of ventilation, it can become a difficult issue trying to intubate these people and ventilate them. You don't have much to work with. They tend to have very high peak inspiratory pressures. It has nothing to do with obstruction. It's literally because the lung will not expand outwards. What you see is you see an alteration in your lung compliance curve. Okay? These people actually respond better to CPAP therapy, okay, because they have a low FRC point. So trying to get their lung to be expanded more actually helps. Typical features is dyspnea with rapid shallow breathing, reductions of all lung volumes, FEV1 to FVC ratio is normal, airway resistance is normal or low, reduced lung compliance, very good negative intrapleural pressure at total lung capacity. Arterial hypoxemia is chiefly due to VQ inequality. Diffusion impairment may contribute to hypoxemia during exercise, but in most circumstances it's not an issue until you exercise. You have a normal or low arterial CO2 in early disease, and later on it does become an issue. The reduced diffusion capacity of carbon monoxide, and you do have an increase in pulmonary vascular resistance. Other types of parenchymal restrictive diseases are depositional diseases like sarcoidosis. Okay, sarcoidosis would also cause it to become a restrictive disease. The other one is hypersensitive pneumonitis, interstitial diseases from drugs, poisons, and radiations, especially drugs like bleomycin. Bleomycin is used for chemotherapy. If you mix that with oxygen, you get a depositional disease, so you get a tremendous increase in fibroblast activity, and literally the lung will fibrose overnight. It's horrible. So if you're working with somebody with lung cancer or any kind of cancer and they're receiving bleomycin, you cannot give them very much oxygen. You're just asking for it. You give them 100% oxygen in the operating room, it won't be bad during the case, but the next day the person's lungs will be white as your sheet in front of you, okay? And the person will be dead within a week. So don't do that, okay? Goodness is most people know that and they tend to alert you to it. But when I worked at the research hospital for cancer, we always asked, the first question was, what's the chemotherapy? And we made sure we didn't have bleo anywhere on the chart. It's very scary to watch how fast it goes and how fast somebody will fall apart. The other bad disease is collagen diseases, can also be collagen deposition diseases, can also do things like women with, usually women show up with this, is scleroderma. Scleroderma is an increase in collagen deposition. Okay, you'll see it in their fingers. Those fingers in their skin will turn pearly white. Their face will turn into a more of a mousy face, narrowed nose, narrowed mouth. And when you look at their lungs, they develop an increasing collagen deposition into their lungs as well. And that's what they usually die of, pulmonary hypertension. You can also have develop what's called lymphangitis carcinomatosa, which is a cancer where the lymphatics develop increasing infiltration by some kind of cancer cell, usually it's lymphoma, and the lymphatics can't clear, and then the interstitial space begins to become excessively edematous, and it causes this kind of disease processes too. Well, sarcoidosis is Bernie Mac had it. It forms granulomatous diseases. The exact cause of sarcoidosis is not known. We think it's an immune response that's triggered by most likely some form of infection that we're still not clear as to what's causing it. What you see clinically is you see tender reddish bumps or patches on the skin. You get red teary eyes, swollen and painful joints. You get enlargement in the lymph glands in the neck, armpits, and groin. You get enlarged lymph nodes in the chest and around the lungs. And the person will develop sometimes nasal stuffiness and hoarse voice. Now, the reason this is such a dangerous disease is because for us, these sarcoid granulomatous lesions can affect the airway, okay? And they're also extremely vascular. Okay? If you touch them with a laryngoscope, they're going to bleed like stink, okay? If you put it in, if they have a nasal sarcoid polyp and you put a nasal endotracheal tube, you'll get massive epistaxis in that individual. Okay, so you got to be very, very careful. Always look before you go, and as you go along, be very careful about what you touch. It also will cause kidney stone formation. You get enlarged liver. You get abnormal heartbeats as well. You get arrhythmias. And the nervous system can also include hearing loss, meningitis, seizures, and including some psychiatric problems like dementia, depression, and psychosis. So this disease affects almost every single organ in the body. You do get conjunctival nodules, and you get erythema nodosum, which is what you see usually in the pretibial area of the person's legs. And in this chest X-ray, what they're showing you is enlarged nodules, especially here, that are inside the lung. Sarcoid can go into different stages, and this is what you need to ask a patient. What stage are you in? If the person is in stage 0, there's no intrathoracic involvement, so the chances of you having a problem with them is pretty small. But if you go into stage 1, that's still not too bad. It's got bilateral hydroadenopathy. You tend to see the erythema nodosum, arthritis, uveitis, and parotid enlargement, but you still don't see a lot of damage to the lung. When you start seeing the damage starting to take place in lung parenchyma, that's when it becomes much more dangerous. And if it goes into stage 3, where you start getting bulla formation, then there's a much higher incidence of a pneumothorax in taking care of this patient. So you got to be ready in the sense that you got to be ready to be able to have to put a chest tube in this individual if you need it. The pulmonary function is a restrictive disease. It's in stage 2 and 3. In the first stage 1 and 0, it's really not a restrictive disease because it's not affecting the parenchymal components. Sarcoidosis can act like an obstructive disease pattern as a sarcoid granuloma forms inside the trachea or in the bronchioles. Okay, so in that case, it would be obstructive. But in stage 2 or 3, it does become into a restrictive disease. Once it goes into stage 3, it becomes more of a collagen vascular depositional disease. Okay, you see lung volumes become smaller. Your FEV1 to FVC ratio stays normal. Your lung compliance is greatly reduced, and your resting arterial PO2 is significantly decreases with worsening with exercise. Next disease process is exposure to different things. It's hypersensitivity pneumonitis. This is a reaction to allergies or exposed allergens from the environment. Okay, so it's an extrinsic allergic alveolitis. Usually it's exposure to occupational and heavy exposure to certain things. When I was a kid, one of the things that we used to have all the way around where we used to live was sugarcane farms. And sugarcane farms go for acres. I mean, just acres. The place was huge. And you guys should be able to go up to the sugarcane, cut it, and you peel it open and you start sucking on it, and you get literally sugar high from it. It's amazing, this stuff. Okay? The downside to it is that the way they actually manage it is that they massively cut it, and then they let it sit on the ground for a day or so, and then they pick it up. Okay? And this is all done by manual labor. Okay? There's two dangers. One is that snakes will kill you pretty quick. Okay, so imagine just cutting through the brush like that. Imagine snakes all sitting there happy as hell. So they're going to really chop you. And the other big problem is that chronic exposure to this is a grass. Okay? And when you have a lot of husk, which is just, that has a lot of husk, there's a lot of particles that go in the air. And that goes inhaled into the lung, and these people will develop this restrictive hypersensitivity reaction. You also have things like this in the United States, which we call farmer's lung, which is due to hay. If you're working with hay and you let the hay get wet, it forms a mold called actinomycosis. Okay? And when you begin to inhale this stuff, it becomes a toxin into your lungs as well, and you get a hypersensitivity reaction. It's another. I know one guy that gets paid really well in Vegas, and his job is actually to take care of all the birds that all the magicians use. And that's just a very, very dangerous job, and that's why he gets paid so well. He's got to clean all the feces of all these birds. The reason it's such a dangerous job is he's doing it inside an enclosed room, and he has to use a grade 3 bio suit to do this. Just think of that. That means you're completely on oxygen, free of environment, with a complete suit on you, okay, while you're cleaning all the feces of all these birds. That's how dangerous this job is, okay? So it's not a joke, okay? And if you don't, you can get avian antigens from feathers and excreta, and you can be very, very sick very quickly from it, okay? So if you like birds, just make sure that you clean your birds very frequently, and you should wear a mask when you're doing it, okay? If your bird gets sick, there's a good possibility that you get psittacosis or some bad disease from the birds, so be careful. I personally don't like keeping birds, so, you know. All my friends, we would keep macaws down there, and I always felt sorry for the macaws. You know what macaws are? Macaws are these huge birds. It's about this big. It's got blue, red, and yellow colors to them. And we used to see them flying over our high school. It's kind of cool. So to keep those birds down, I don't know. That just didn't seem right. Anyways, you got bagosis as well, and you have air conditioned lung, which is like Legionnaire's disease. So there's a lot of things that you can sort of be exposed to that on chronic, it causes alveolar wall thickening and infiltration. Here's what actinomycosis looks like. Okay, it's a gram-positive bacteria. Okay, and what happens is it actually infiltrates into the skin. This is a young man that basically wounded himself when he was doing hay work. Okay, and look what happens. Look what his skin does. Look what they had to do. They had to cut it off. Okay, so actinomycosis is not a joke. If you get actinomycosis in your lungs, you're really in trouble. okay? Because they can't cut your lung out like that, okay? But you can see the extensive infiltration. You see all these little red dots here? That's a gram-positive bacteria. There's such a heavy load there that they just couldn't treat it with antibiotics. Okay, so sometimes you have to remove it. You also get this kind of drainage from the person's neck, okay, from the lymph node being infected from when you breathe it in. And if you get into your lungs, you'll get this kind of abscess inside the lungs. Not something you want to see. These are hard to treat, to say the least. The best treatment is make sure that you wear a mask, make sure that you're wearing clothes that doesn't prevent you from getting abrasions. So don't do that kind of stuff. Hypersensitivity pneumonitis is an acute wise. You get a fever, shivering, and usually the cough lasts 4 to 6 hours after exposure and lasts for 24 to 48 hours. And the person develops dyspnea at rest. Over time, as the lung begins to infiltrate more with collagen and fibrin, it starts causing dyspnea at rest, and you get fibrosis mostly to the upper lobes. Pulmonary function test, you get early, you get an obstructive pattern. Once it becomes well established, it becomes a restrictive pattern. Okay? It's a reduced lung volumes, low compliance, and hypoxemia is very prevalent. Then you have interstitial disease caused by drugs, poisons, and radiation. Okay? This is not a joke. This is not a doctored photograph. This is actually a real photograph of amiodarone. Okay? Amiodarone is also called the blue Smurf drug. Okay? This is why. See the blue? That's amiodarone toxicity. Okay? If you wait too long, it turns green. What the hell was somebody thinking? You know, normally people don't walk around as green like a, this looks like a green goblin. Okay, now what were they waiting on? Okay, I don't understand. But so you stop the medication, it mostly reverts back to normal. Okay, but you got to stop the medication. Bleomycin is very dangerous. Okay, oxygen therapy. You see how the lung turns white? This does not come back. These people die. If you give them oxygen and bleomycin together, it'll be a hypersensitivity, very rapid fibrosis and reaction taking place, and usually the person dies very promptly within a week. Okay? Collagen diseases, you have scleroderma. Somebody famous most of us know, Robin Williams has scleroderma, which is rare for males, but he's one of those unfortunate males that has it. What happens over time is you develop narrowing of your face. You develop these kind of skin changes here on your hands. Your hands turn into almost like pearls in their coloration, the whiteness, the skin, because you don't get any more blood supply. It begins to basically self-amputate your fingers. Okay? It limits the perfusion to your fingers so much that eventually you lose your finger and digits. Okay? Usually at that point, though, you also have very severe pulmonary hypertension, and usually you don't die so much from the amputation of your fingers, but you die from pulmonary hypertension. Okay? You tend to get a very significant dyspnea out of proportion to the situation that the person appears to be in. It's because of the high amount of collagen deposition that they're getting in their lungs, and it produces a significant VQ abnormality. The other disease process that also will cause collagen deposition will be lupus. Okay, this is the wolf. That's why it's called lupus. It's a wolf's kind of appearance. Okay, you will see this in young women mostly. Okay, you also associate with it is Raynaud's disease with lupus as well as scleroderma, and then you may also have rheumatoid arthritis where you get joint destruction. It also begins to cause collagen deposition in the lung, and also causes very significant problems with your cricoid membrane, and also with your retinoids properly working. So people that have rheumatoid arthritis can be very difficult to intubate, okay, because they get a fusion of C1, C2, and the other issue is that their trachea is very narrowed, so it can be difficult to get a large size tube in. So somebody with rheumatoid arthritis, you better have a small size endotracheal tube available. This is lymphangitis carcinomatosa. This is an infiltration cancer via the lymphatics. Okay, you can see the lung's completely whiting out. The lung is whiting out because fluid can't get out of the lung, so the lung just becomes pulmonary edematous, and the person basically drowns in their own secretions. Now let's go on to the next set of discussions. A simple pneumothorax. Okay, A simple pneumothorax won't kill you. Okay? It only kills you if it goes into a tension pneumothorax. A simple pneumothorax just means that the lung is collapsed, but it's not really compressing on the mediastinal structures. So it's not really affecting the heart. The results basically occurs when the potential space between the lung parenchymal wall and the pleural wall separate. Okay? And it causes a loss of negative pressure and causes a partial or total collapse of that lung. What you see in this situation is signs and symptoms is basically it acts like a drum, so you see hyperresonance of the affected hemithorax. You'll see decreased or absent breath sounds on the affected side. The person will develop some degree of dyspnea. Okay? They'll get sudden onset of pain, which is radiating to the shoulder of usually the affected side. And you'll see an elevation in the chest wall on the affected side as well. Intervention is if you have a 30% pneumothorax, you can treat it with high flow oxygen, and a lot of times the pneumothorax will resolve by itself. You don't have to put a chest tube in everybody, is what I'm telling you, as long as it's under 30%. Once you go above 30%, high oxygen flow therapy is really not going to work. Then you need to consider doing a chest tube as soon as possible. There's two kinds of chest tubes that we can use. You can use a Cook catheter chest tube, which is a small little chest tube, or you can use a surgical chest tubes, which are the size of your thumb. If it's a simple pneumothorax, a Cook catheter works fine, and you put it anteriorly, and you have the person laying down, so most of the air goes up, so they're able to remove that. If you have fluid in the lung as well, then it's better to put it posteriorly, and you're better off putting a larger size chest tube in that situation. Now, an open pneumothorax is something that you'll never miss once you hear it, okay? Because it's got a sucking sound. It sounds very much like this every time the person breathes. When you first hear it, you're going to go, wow, that sounds really bad. There's a certain amount of, I think, primordial fear, and you hear an open sucking chest wound that you'll never forget. Okay? People told me that when they first taught me this stuff, and I said, nah, it's not going to put any fear in me. It's going to be not affect at all. And then I heard it one day, and it's like, wow, that sound that I really don't want to hear again. Okay? This does not sound good. Okay? And every time the person's taking their breath, that sound comes back. Now, what you want to do in that situation is you want to cover the wound as fast as you can, but you don't want to cover the wound so it converts into a tension pneumothorax. You want to just basically leave one side open so air can come out, but you don't get a bunch of dirt and stuff into the chest. Okay? Because every time that person is making that sucking sound, it's sucking in environmental toxins, sand, dirt, dust, fibers of cloth, whatever is in there is going into the chest. So this person has a much higher incidence of developing an empyema or an infection inside the chest wall. What you see is this usually is due to high velocity weapons, such as a round or shrapnel injury can also cause this. This is a military picture of somebody injured with a sucking chest wound. Effective ventilation is significantly impaired, leading to hypoxia and hypercarbia. If you don't treat it appropriately, it can convert into a tension pneumothorax, which will kill you very fast. Again, this is another kind of sucking chest wound. This injury pattern is and again, another shrapnel injury. You can see that the skin has basically been denuded right off. What you have to do with these individuals is take them to the operating room, clean up the edges and the borders of the skin, and eventually you put in a skin graft. Okay. Signs and symptoms is the person develops dyspnea, chest pain. You see a penetrating wound to the chest. Hyperresonance in the affected hemithorax. You see decreased or absent breath sounds. And what really is pathognomonic is a sucking sound on inspiration. This is a new thing that we have available. It was designed for the military. It's a device that's got little valves in it. So what you're able to do is you peel off the plastic and you slap it onto the wound. Very quick. The nice thing about it is it's got a one-way valve, which prevents air from coming in, but it allows air to go out. So the person does not convert into a tension pneumothorax with this device. It promptly closes the defects with sterile occlusive dressing, which is large enough to overlap the wound's edges. Usually if you only have 4x4s, that's what you use with, usually we'll try to use on top of that with a petroleum jelly on it, so it occludes it, because just a regular 4x4 won't occlude the air. So you really need to have some kind of petroleum-laden material to prevent the air from coming in. But you leave it taped securely on 3 sides if you're using that device to allow the air to go out to one side so you don't get a tension pneumothorax. If you do start getting signs of symptoms of tension pneumothorax, which we'll show you in a minute, then you've got to take this occlusive dressing off immediately. Okay? Definitive therapy, of course, is chest tube, and therefore rapid transport to appropriate facility. Tension pneumothorax is what really kills you. Okay? We'll talk about this again when we talk in trauma lectures. What happens in a tension pneumothorax is you develop a one-way valve where air is able to come into the chest but it's not able to escape. Air basically begins to entrap and begin to compress the structures in the mediastinum and in the opposite direction. And it will actually cause almost like a cardiac tamponade effect, but it's due to air, not due to fluid around the heart. So the heart begins to collapse. You can see huge jugular venous distension taking place. When you do the chest x-ray, the pneumothorax will be evident, plus mediastinal shifting. Remember, the heart's normally supposed to be here. That's where the heart should be. Look where the heart's at now. It's right here. That's pretty compressed. That's a tension pneumothorax. Okay? So you don't get venous return coming back, so you get huge jugular venous vein distension. The breath sounds are absent on that side of the chest. The chest wall is actually hyper elevated, so it's easy to see, and you will see hyperresonance when you percuss it. The causes of this could be from positive pressure ventilation with somebody with a lung injury. A simple pneumothorax can also follow a penetrating or blunt chest trauma. It can occur. Misguided central line placement can do this as well. Incorrectly covered chest wall injury with an occlusive dressing, such as an open pneumothorax, can cause this. And a markedly displaced thoracic spine fracture can also do this. I've also seen this happen from a surgeon putting a screw into the chest. Okay, so because they're doing a thoracic laminectomy, and then they were putting in pins in the back to stabilize it. They drilled right into the pleural space and knocked down lung down and causing that tension pneumothorax. So it can be pretty hairy in the operating room some days. Signs and symptoms: you get chest pain, air hunger, respiratory distress. Usually you get tachycardia because it acts like a tamponade effect. Hypotension is pretty evident. Tracheal deviation away from the injury side. That's an important notice. Please don't put the needle on the other side. It's a bad mistake. If you do, then oh well, put the other needle on the other side. Now you got 2 simple open pneumothoraxes, and the person's not going to die at that point. Okay. When you put in an IV, which is usually a 16 or 14 gauge IV, in the second intercostal space of the midclavicular line, when you insert it into that space, if you hit a tension pneumothorax, it'll be dramatic. When you pull the needle out, you'll hear the angiocath go like whistle at you. The higher the pressure, the higher the whistling sound will be. And the patient will immediately respond by becoming hemodynamically stable. Okay? It's amazing. The heart rate immediately comes back down. The person says they can breathe again, and it's amazing how fast it can make a difference. Okay? You get neck vein distension is pretty prominent during the tension pneumothorax, and develop significant cyanosis. Intervention is immediate decompression, rapid insertion of a large bore needle in the second intercostal space in the midclavicular line. Convert the tension into a simple pneumothorax, and the definitive treatment eventually is placing a chest tube. And what we tend to teach you if you decide to put in a chest tube is that you can put it at the mid-axillary line, usually, right around the nipple area, so you prevent you from going into the liver or the spleen. Please don't go below the nipple line too much, because I've seen people put trocars into the liver. That's a bad day. Or also I've seen somebody put a trocar through the spleen. So not a good day. I don't use trocars myself. I use a hemostat. And what you do is you make a small scalpel incision after you infiltrate with local anesthetic. Then you take the hemostat, which is a blunt tip in device, and you feel it as it goes over the top of the rib and you push it in and you feel a pop. As soon as you feel the pop, you take the hemostat, open it up, and then you put your chest tube in. And it's that fast. It doesn't take very much. Once you get trained on how to do it, it doesn't take much. Okay? And you should learn how to do that because, again, you do put central lines in, and eventually, if you don't have anybody to help you, if you're the single provider, you might be the one having to put the chest tube. Especially if you are a medic, or if you're working as a nurse anesthetist in a field hospital or something like that, this is something you might want to learn how to do. Otherwise, most of the time, it's really outside your scope of practice. You tend to call somebody for helping you at that point. A massive hemothorax is, this is lead intoxication. Nobody left. Okay. Okay. Lead intoxication, which means a bullet wound. Okay. So this is a pretty big slug. Mostly hit a pulmonary artery. So what you see in this individual is you see a massive hemothorax. That's why it's white on this chest X-ray. So all this area here, this is the lung here, and all this is blood. Okay? You see that okay? So if you want to see you want to see that there's blood, sit the patient up. This is the person that was supine. See? The person is flat. That's why the blood is sort of, you can't tell there's any line. If you sit the person up, you'll see that the blood will form into a level. So one of the things that you want to do a hemothorax is you want to do a chest X-ray with the patient sitting up. When you put the chest tube in, you may see a very, very bright red blood coming out. If that's the case, that person better go to the operating room right now. That means they hit a pulmonary artery, and that's not going to stop bleeding. Okay? Please, 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 please do not leave the chest tube open. Okay? Because you will never get to the OR. The person will exsanguinate on you. Okay? So after about 1,000 cc's coming out of your chest tube, cross clamp it. Because at least 1,000 cc's that's in the chest is acting like a tamponade. Okay, now I'd rush to the OR and get the guy fixed. You might have to do what's called a pneumonectomy, which means that you've got to remove the whole lung to save the person's life. But you do what you need to do. Okay? If you lose your blood pressure and you got no more pulse, at that point you should ask the surgeon to do a pneumonectomy. It's the fastest procedure. Okay, it takes literally 35 to 40 seconds if done by the surgeon properly. You'll put a cross clamp across it, and all of a sudden the preload will return back to the heart, and the person will come right back. Okay, if you wait too long and you start trying to muck around doing a segmentectomy or a partial pneumonectomy, then you're just hemorrhaging to death, and you're never going to catch up. Causes are usually penetrating wounds that disrupt the systemic or hilar vessels. Most people don't survive to get to arrival, so usually it's a smaller blood vessel in the periphery. The ones that get hit in the pulmonary artery are usually die in the field. You can also get blunt injury, where deceleration injuries can also take place, can also induce this. If you're seeing this in the left side of the chest, worry about a dissection with possible aortic rupture. Signs and symptoms. The difference between this one is that you do get dyspnea and chest pain, but you get dullness on the hemithorax. Okay? And why the dullness? Because now the chest is actually filled with fluid. So instead of getting a hyper-resonant sound, you get a dull sound. You still get a decreased breath sounds, and you still get a tracheal shift away from the injury pattern, but the patient becomes very shocky and hypotensive. Intervention is aggressive crystalloid therapy. We're really trying to go away from that. We tell you go to the OR now. Give type-specific blood if you can, and you can decompress the chest cavity just a little bit, but once you get above 1,000 cc's, really consider cross-clamping the chest tube so the person won't continue to hemorrhage to death on you. The next disease process is the pleural effusion. Pleural effusions there's two kinds. Actually, I'll stop here, give you guys a 10-minute break, and we'll start back up on this.